A very good afternoon to one and all present here. Our respected guest of honor, our director, Dr. Deepak Nalaswamy sir, Dr. Deepika Deka ma'am, our respected speakers, Dr. Deepti Jami, Dr. Malati Prasad, Dr. Sudarshan, Dr. Bhuvana, and Dr. Rajlakshmi. I welcome our dear faculty of Savita Medical College, our head of the department, Dr. Jayashree ma'am, Dr. Rohini, Dr. Shanti ma'am. Thank you all for joining us on this lovely afternoon for the webinar for Down Syndrome Awareness Day. We'll begin with the welcome address. I request our Professor Dr. Hepzibah ma'am to welcome our guest of honor.
Very good afternoon to one and all. Respected Deepak sir, Director of Academics, respected Deepika Deka madam, it's my proud privilege to welcome you all. It is my honor to welcome Dr. Deepak sir, Director, Academics, Savita University SIMATS, Program Director, Savita Academy of Dentistry, who is always been supportive to us, encourages in all our endeavors. He motivates us to do newer technology, digital innovation, research, and publication. In spite of his busy schedule, he has joined us. So we welcome you, sir. Dr. Deepika, my old friend, a former VC of SS University of Health Science, senior consultant in fetal medicine. She has done a lot of work on genetics and fetal medicine. We welcome you, madam. In spite of your sickness, you have joined us. And I welcome our renowned speakers, Dr. Deepti, Dr. Sudarshan, Dr. Malati, a fetal medicine specialist, and Dr. Rajlakshmi and Bhuvana from Ramachandra. And I welcome one and all the dear delegates. I'm sure today you will be benefited. The March 21st has been officially observed as World Down Syndrome Day. This is selected to signify the uniqueness of trisomy 21. Third month date is 21. Because of this abnormality, aneuploidy, they look different and learn differently. They have different problems like heart disease, hearing loss, eye problems, and they require so much health needs. But due to advances in technology, we are able to predict about this trisomy much earlier, about 14 weeks. And today, I'm sure the webinar is going to be very useful, and it is based on the theme, how early we can predict pregnancy, whether it is normal or abnormal. What can we do if we detect aneuploidy early? This is all the things that we are going to discuss. I'm sure the audience will be benefited by this webinar, and it will help us to face day-to-day problem. Once again, I welcome one and all. Can you project sir's CV? Sir, Evangeline, can you project Dr. CV? Can you zoom it? Yeah, it's my privilege to introduce our director, Dr. Deepak Nalaswamy, Director of Academics, Savita University, Program Director, Savita Academy of Implant Dentistry, Professor, Department of Prosthetic Entities, STC, Ambassador, International Congress of Oral Implantology. He has won many awards. If I keep on reading it, I think we will go to the next day. One of the best, he was one of the best outgoing dental graduate, aggregated at STA, the 77%, gold medal in pharmacology, general pathology, general medicine, general surgery, oral medicine, prosthodontics, won silver medals in anatomy, physiology, microbiology, oral anatomy, and second best dental graduate at MGR Medical University. This reminds me one Tamil, this thing, Vilayum Payir Mulaile Theriyum. And Best Teacher Award at Savita Dental College, PIGO course at Germany, Best Teacher Award at University of Toronto, Young Achiever Award, one Best Paper at IDAR Korea, one Pioneer in Dental Education Award at World Dental Congress, Director of Savita Academy of Implant Dentistry, which has placed over 4,000 implants with 99.6% cumulative survival. Completed implant course in Canada, Brazilian implant course in Canada. He has published many research, international and national level. And we are proud to have you, sir, Director, sir. Over to you. Please say a few words of wisdom and share with us, sir. Over to you, sir.
So good afternoon to all the dignitaries who have present for this August webinar. So it is indeed my great pleasure that, and I'm also privileged and happy that our OBG department at the Savita Medical College are organizing this webinar. So fetal medicine is a very, very trending and a very sought after discipline in OBGYN, and with the number of chromosomal abnormalities almost reaching 1 in 150, and Down syndrome is 1 in 800 births. I think that should be around the number. So that is a significant amount of the population are being affected, especially for a populated country like ours. So I think this webinar where you're looking for anomaly scan and looking for methods to manage Down syndrome would definitely shed lights to more and more practitioners so that it's more ably maintained. I have read a lot of articles on CRISPR-Cas9 and its impact on seizing the third chromosome. I think the 21, right? I'm not kind of familiar with it, but the 21st chromosome, the third chromosome, there are precise gene editing tools to cut away the third chromosome, which could be done, I believe, around 15 to 18 weeks also after pregnancy. And there is a lot of active research going on, because when we were at Harvard, this was one of the things that was heavily spoken about and as a holy grail in treating these conditions. So in India, I don't think there are many people who work on CRISPR-Cas9. I strongly implore each and every one of you to look into the impact of CRISPR and Cas9 and how it can be brought into therapeutic aspects as well. Apart from that, a passionate care and a good early management of Down syndrome can also benefit, because even though the disease is mentally debilitating, there are a lot of success stories where some people have grown up to become reasonably adapted into the society. So as a social construct, it is our responsibility to also ensure that, more and more of differently able people are given provisions to have a stable and a decent quality of life, so to speak. So with those few words, I really congratulate the OBG department for organizing this program. And I also congratulate all the faculty who are participating and the guest speakers. I hope it's really enlightening for all the participants, and more and more research is poured into this to eradicate this disease. With those few words, I'd like to thank and hand over my portion.
Thank you, sir. It was really motivating speech. We'll encourage everyone to do some research on this line, which will be useful to the next generation. We can prevent certain diseases like Downs. Thank you so much, sir, for joining and gracing the function. Can I have the Dr. Deepika's CV? Can I have the Dr. Deepika's CV? Yeah. It's my proud privilege to introduce Dr. Deepika Deka. She's one of our old friends who is very much keen on starting fetal medicine unit in AIMS. She is a senior consultant in fetal medicine and global Galaxy ultrasound Dwarka sector. She's the areas of interest is fetal medicine, high-risk pregnancy. She's a president Dwarka Delhi Gynaec Forum. She's a former unit head in maternal fetal medicine in AIMS, Vice Chancellor, SS University of Health Science, Government of Assam, Director AIMS Kalyani, Kolkata, West Bengal, past President and Founder, Vice President, Society of Fetal Medicine, past Chairperson, Genetic and Fetal Medicine Committee of FOXI, Fetal Medicine and Genetic Committee of AOCGD Delhi. Over to you, Madam Dr. Deepika. to say a few words of wisdom to us.
Thank you, Dr. Hepzibah. Thank you for inviting me. It's always a pleasure. And I remember that you were in my committee during the FOXY and you were very interested in fetal medicine yourself.
Yes.
I think it's very appropriate that you should be celebrating awareness, celebrating this program and creating awareness. And it's been a lot of people. I'm very happy that so many societies I have been involved with today, this last week, where we have been spreading awareness about Down syndrome. There were days when actually you could diagnose Down syndrome only after birth. But with the advent of ultrasound and with the advent of biochemical screening, we could do that in the second trimester. But now, with the work of so many researchers, the time that we can do the screening for Down syndrome has come down to as early as 10 weeks of pregnancy, reliably. So at 10 weeks of pregnancy, especially in the high-risk cases, we can do NIPT at 11 to 13 plus 6 weeks. We can do the nuchal translucency scan. We look at the nasal bone. We can look at the tricuspid regurgitation. We can look at the ductus venosus and so on. And also we can do the double marker and do the combined screening. So this is the package in the first trimester, which is very effective. Later on, of course, if the patient does not turn up earlier, and the second trimester, we can do the quadruple marker, pentaple marker. We don't do the triple marker anymore. And of course, we can do the genetic ultrasound. The genetic ultrasound is the one which is done at 16 weeks, where we look for all special soft markers for Down syndrome. And then, of course, you have the traditional ultrasound second trimester, which is done at about 18 to 22 weeks now, because the sorry, we can terminate the pregnancy anytime, best before 24 weeks. So with all these developments in the field of diagnosis and screening for Down syndrome, which can happen, I have seen in AIMS young girls, 20, 25, giving birth, who have been referred to us, previous child with Down syndrome. And of course, we can do the post-delivery therapy, but no parent would like to have a second child with a Down syndrome. And why second? Why not the primary one? So it is very important for us to prevent birth defects, and Down syndrome is a very important and common birth defect. So it is very useful, this CME, to spread awareness for Down syndrome screening. First of all, the obstetricians actually should know what is Down syndrome. And then, of course, who are the women who are at higher risk of Down syndrome? But we are screening everybody universally, because most of the societies have decided that we have to do screening for Down syndrome for every pregnant woman, not just women above the age of 35. The other development is that instead of doing amniocentesis, I remember 10, 20 years back, all the women who were above 35 years, we used to do amniocentesis. Now, you don't need to do amniocentesis for all. We have the NIPT, we have very good ultrasound markers. So many developments have occurred in the field of screening for Down syndrome. So I'm sure they will all be discussed, and I wish this CME all success. Thank you for inviting me. It's been a pleasure. I wish you all success.
Thank you so much, Dr. Dika, for the words of wisdom. It was very useful. I think we have to know, as an obstetrician, we have to know how to detect early and how to prevent and other things, apart from research also. Thank you so much. Can you display Dr. Jayshree's CV? Jayashree and Dr. Rogini.
Thank you, ma'am, and thank you, sir, for your wonderful words of wisdom, and thank you for joining us today. We will begin the first session of sonographic assessment of fetal anatomy at 11 to 14 weeks by Sudarshan, sir. Our chairpersons will be our head of the department, Dr. Jayashree ma'am, and our professor, Dr. Rohini ma'am. Sir, kindly display the CV of Dr. Jayashree ma'am. Professor Jayashree ma'am is our HOD, Department of Obstetrics and Gynaecology, Savita Medical College. She is the retired director in charge of IOG, Madras Medical College, past president of OGSI in 2013 and vice chairperson of AICOG in 2015. She's also the best outgoing student of Chengalpet Medical College and has received the A.R. Murlia's Traveling Fellowship. Awards received are Best Teacher Award by the Tamil Nadu MGR Medical University, Lifetime Achievement Award by Chengalpet Medical College. She has presented many papers in national and international conferences and published papers in national and international journals. She's also organized many workshops and conferences outside and in Savita Medical College. She has recently contributed to a chapter on ethics in the new edition of Murlia's textbook of obstetrics and FOGSI focus on prostaglandins. We welcome you for this session, ma'am.
Thank you. Thank you, Evangeline, for the nice words. On behalf of OBG department, on this day of spreading awareness about Down syndrome, I thank our director and Dr. Deepika Dekka for having graced this occasion. And thank you for your valuable words. With this, myself and Dr. Rohini will start this session. And I'm very happy and proud to introduce the young speaker, Dr. Sudarshan. Can you please show the... Please show the...
Sir, can you please share Sudarshan sir's CV?
Dr. Sudarshan is not, he is very much known to us. He has been with us in this department for quite some time, and he is the tip of gold block, and very proud to introduce Sudarshan. He has done his MBBS from PG Medical College, PSG Medical College, and he has done his PNB from Railway Hospital, Chennai. And he has done his fellowship under his great father in Mediscan system, and he has acquired maximum knowledge, and he has really, we are very proud to have you here, Sudarshan. You have done wonderful work on amniocentesis and about organizing protocols for the specialist unit in fetal medicine, and you are guiding students too in paper publications, etc. Thank you so much, and I request you to give a talk on sonographic assessment of fetal anatomy at 11 to 14 weeks of pregnancy. Over to you. Dr. Sudarshan?
Yes, madam. I'm just logging on. I'm just trying to open my presentation, madam. Just give me a minute, madam. I'm just having some hassles here. Just give me 1 minute.
As Dr. Deepika very rightly said, during our student days and during our younger days, we were able to diagnose Down syndrome only after the birth of the child. But now we are really privileged to have it diagnosed very early in life, in fetal life, so that we could take correct actions. And as we were taught earlier that maternal age was the major factor, we are finding that it is not so. So that is why the need for universal screening for this Down syndrome during the first trimester itself.
It's the same thing only, Noram here.
Yes.
Can we ask Malati to present? Meanwhile, you set it down.
No, I think I'm on, madam. I'll be done.
Okay,
Yes, I'm just,
okay.
just come. Some small hassles, that's all. So I think I'm fine. I'm not able to share my screen. Can you enable to share my screen, please?
Dr.
Dr.
Balaji,
Sir, can you please give access?
Yeah,
not-
it's already on.
Now only it's on. Okay, okay. Is it in full screen mode?
Yeah.
It's in full screen mode, no, madam. You can see.
yeah. We can see.
Okay, madam. Thank you so much. A very good afternoon. I'm sorry for that technical hassle when I was logging on. So I wish to thank the organizing team for making me part of this webinar on regards World Down Syndrome Day. In fact, today I had the good fortune of being part of a Down syndrome program at Voluntary Health Services Hospital, where we had a very large number of families and children with Down syndrome who were there, who were doing a wonderful cultural program also. So with this start, so what I'm going to do probably over the next 10 to 12 minutes is give you some details on evaluation of the fetal anatomy in the first trimester. And when we look at evaluation of the baby, our focus of assessment has shifted dramatically from a large amount of assessment, which was traditionally being done in the third trimester, to a shift to the second trimester. And over the last decade or decade and a half, we have started giving a lot of focus on assessment of the baby in the first trimester. So when we look at assessment of the baby in the first trimester, we always think and look at it from the perspective of screening Down syndrome all the time. And when we look at the data and look at the numbers, the prevalence of a baby having Down syndrome in the first trimester is probably around 1 in 900. That's the population risk. But when you look at structural malformations, they are much higher. So what we should start doing is start calling the first trimester ultrasound not as a NT scan or the scan to assess for Down syndrome, rather relabel or recall it as a first trimester early anomaly assessment, because that's the key focus that we have at the 11 to 14 weeks over and beyond the evaluation for aneuploidy. So this session will be on imaging the normal anatomy of the baby at the 11 to 14 weeks. And I think it will be followed by a talk on structural malformation. So I'll restrict myself to doing a stepwise assessment of the baby at the first trimester scan. So how have we been seeing this? We started systematic first trimester scans in 2006 with some protocols, and by around 2010, in 4 years time, a separate unit for handling first trimester scans had to be segregated, considering the number of referrals and considering the complexity in assessment of the baby at this time. And we established our rule of two, which is a very stepwise process of evaluation of the baby, or a checklist based approach. And from 2014, it's been almost a decade since we started doing extended first trimester cardiac assessment of the baby. So this has increased our evaluation of structural malformations and helped us provide a lot of evaluation, a lot of clarity to families as early as this point of time. The International Society of Ultrasound in ONG has now set up guidelines for first trimester anatomy assessment in 2013. That was 10 years ago. And in 2023, they have reassessed the whole thing because of the changes that have happened over the decade. So let us set some rules straight. Who are the people who can perform the first trimester ultrasound scan? Because traditionally training has involved doing a lot of assessment of the anomaly scan or the second trimester scan. And since we have shifted this to the first trimester, again, someone who has underwent a complete training in evaluation of the baby in the first trimester, who know the challenges, who know the differences in the embryological development of the baby in the first trimester, and they know how to have appropriate care pathways when you see abnormal findings or borderline findings. These are the people who should be doing the first trimester scan. We cannot consider this 12-week scan as part of the routine assessment where we can just screen the baby and get them back for a routine anomaly scan at 20 weeks anymore. We are gone past that phase where we use the 12-week scan only to screen the baby, and we use the 20-week scan to assess the structural malformations, which again lays the focus on what ultrasound equipment we should use to do this assessment of the baby in the first trimester. Again, to do a first trimester assessment, you need to have appropriate machines and machine settings, because all machines do not have the capability of providing your high-end images and your color Doppler settings, which are useful for a 12-week baby, because the settings of color Doppler, the settings of transvaginal scan to evaluate a 12-week baby are diametrically different from that of a 20-week baby. So you need to have higher resolution. You need to have the ability to focus and evaluate the color Doppler in different parts of the baby to get that. So the use of transvaginal scan to assess the anatomy is no longer an addendum. Transvaginal scan is part of the first trimester anatomy scan. In fact, I would push it on to say that anatomical evaluation of baby in the first trimester can only be completed in a vast majority when you complete it with the transvaginal scan. And the machine must have the ability for zooming and freeze framing. Though we can say that these have become a routine part of most of the machines, some of the lower end machines which are used as part of the OPD setup don't have all these facilities, and should refrain from using machines which do not have these facilities for doing a first trimester scan. The third question is the first trimester ultrasound safe? Because now, because we are laying a focus on assessment of the anatomy, we no longer do a quick screening and come out. We do a very detailed assessment. Scanning takes around 15 to 20 minutes at least, like how we do a targeted scan. And at this time, though ultrasound is very, very safe, we need to keep the acoustic output as low as feasible. And the areas where the acoustic output is more is color and pulse wave Doppler. So whenever you use B mode ultrasound by transabdominal or transvaginal imaging, it is very, very safe. But when you shift over to color Doppler or spectral flow Doppler or power Doppler, because we now say that we're going to use them routinely at this point of scan, we have to keep the acoustic output as low as possible, and we have to use it very specifically so that we give the least amount of thermal index or of thermal power output to the baby. Doing the uterine artery Doppler is first trimester is very, very safe. It does not have any significant fetal implications. And how should the reporting be in the first trimester? The report must have a very specific format. It must have the indication. It must have the case history. It must have the uterine Doppler pulsatility index. It must have a survey of the baby, the biometric parameters, how the aneuploidy markers are, what are the anatomical assessments seen, what is the gestational age assignment, and what is the care pathway beyond that. So a very systematic reporting method also must be followed at the end of the first trimester scan to complete this whole process. In sum, we are not able to perform the imaging to the extent as feasible. And this usually happens in two circumstances: at the extremes of gestation where the baby is very, very small, say the CRL is between 45 or 50 mm. And in these situations when it is there, we just have to wait and review the scan in 2 weeks' time. It's no longer appropriate to say that at 45 mm baby, we have seen the NT and we have done the biochemistry to do the aneuploidy screening. Let's just get them back at 20 weeks to do the anatomy just because the baby is small. As I said, a lot of focus has to be there on the anatomy. If you are not able to complete the anatomical assessment, we do the screening and get the patient back in 2 weeks' time to complete the first trimester anatomy as per the checklist. So this was the ISUOG practice guidelines, which was a checklist of first trimester scan in 2013, a decade ago. So in the head, they wanted to see the presence of the calvarium and the fox and the choroid plexus filling the ventricles. And in the neck, they wanted to see the nuchal fluid assessment. And then in the chest, they wanted to see the symmetric lung fields and that there should be no effusions or masses, and to check the cardiac activity alone. In the abdomen, the guideline wanted you to see only the stomach, rest were not mandated. In the abdominal wall, it was mandated to see the cord insertion site. In the extremities, we had to see 3 segments, and we wanted to see the placenta. So that's all was the ISUOG guidelines 1 decade ago. You only had to rule out acrania, you only had to rule out large nuchal fluid collections, and you only had to rule out presence of cardiac activity and presence of cord insertion site. This was our initial rule of 2 checklist. We extended the ISUO guideline little better in 2010 itself. And this guideline, what we did was we tried to evaluate the baby from head to foot, and we had 2 parameters to see at each level. For example, in the head, we wanted to see the calvarium and the fox. In the face, we wanted to see the orbits and the maxillary triangle. In the spine, we wanted to see the spinal column. In the heart, we wanted to see the cardiac inflows and the cardiac outflows. In the abdomen, we wanted to see the stomach and the bladder. And then the limbs, 2 upper limbs, 2 lower limbs, 2 hands, 2 feet. And then we looked at 2 markers for aneuploidy, which is the nuchal translucency and the nasal bone. And we had 2 miscellaneous markers, the cord insertion site and the ductus venosus. So we had to remember, it was easy, 2 areas to see in each part so that we make sure we don't miss anything. And this stood us in good stead. But then things improved and changed, and we realized even this was not enough. And we extend this assessment to a more detailed thing. What I've put in this complex slide is the latest ISUOG guideline, which is the 2023 guideline. And they have expanded the number of images to be taken, and they've expanded what is to be assessed in each part of the baby. And this, I would say, will help you rule out over 70% of major malformations as early as the first trimester. I'm not going into each of this in a checklist-like manner. I'll take you through with images. But what the slide is essential to say is in 1 decade, the checklist-based approach has gone from this small box to this extended box, which has involved a large amount of assessment. And all those small stars they had put in this guideline, all these stars are those which are optional. All of them have become now mandatory, and newer things have also been added to the mandatory guideline. For instance, in the heart, We no longer can just get away with seeing the heartbeat. We have to establish the situs, the cardiac position, the four-chamber, the cardiac inflows, the cardiac arches, everything as part of the first trimester scan. So let's start the systematic process of assessment. This assessment starts with the fetal environment, and we assess the environment. We evaluate the uterine contour to see if there is any major uterine malformations. You look at the placenta, we screen for liquor and activity and number of fetuses, and we look at the adnexa. And always start evaluation of the baby from the environment, because suppose you do the scan, you don't see a good amount of liquor, then you raise alarms at that time itself. So once you're done with the environment, you go to screening of the baby. Screening of the baby is just one sweep of the baby in a transverse view, because this sweep of the baby from the head to foot, so you zoom the baby from the head to foot, we just sweep the baby in the sagittal plane, and here I'm sweeping the baby in the transverse plane. And one sweep, we can know if there is any hydrops, large fluid collections anywhere. And as I'm just sweeping across the baby, I know if there are any large body wall defects, because if there are any body wall defects, you can see things would be protruding from the abdomen. And when I'm sweeping up to the head, I can see if there are major calvarial defects. And because I'm sweeping across, I'm able to see the limbs also, major limb malformations like absence of limbs can be seen. Very, very, very important step. Spend quite a bit of time on this screening of the baby or sweeping of the baby from head to foot in the first trimester, because this rules out these major problems at one shot. Then you move on to the next step, which is a systematic assessment of the anatomy. And when you assess the anatomy, I tend to start from seeing the situs of the baby. We see the head to foot biometry of the baby. I see the calvarium, I see the head assessment. And we look at the right left of the baby and make sure that the stomach, the heart of the baby, all are on the same side. And when I'm doing this screening, I've taken the head biometry, I've taken the abdomen biometry, and I have also looked at the fact that the heart of the baby is there on the same side of the stomach. So at the end of the screening sweep, I also complete the biometric assessment, and I also complete the assessment of the situs of the baby and make sure that the organs are appropriately placed. So this assessment, this checklist gives you that. So this checklist gives you at the end of the screening step, the situs of the baby, the heart of the baby, and the 4 quadrants, and the cardiac inflows and the outflows, and the fact that all of them are on the right location. And this screening assessment of the heart, we tend to complete at the end of this initial screen, because we will be able to address any major complications in the cardiac development at this point of time. And with respect to this, we see the 2 cardiac inflows and we see the cardiac outflows. With respect to the 2 cardiac inflows, we only have to make sure 2 yellow lines are there when the baby is showing the heart anteriorly. And to see the cardiac outflows, we only have to see these 2 blue lines as a tick mark that rules out these cardiac malformations. Yeah. And when we look at the anatomy from the head, in the head of the baby, we got to look at the calvarium. And this calvarium is seen as a white line. It is interrupted by these black spaces. These are the sutural lines. And this calvarium is divided by this fox, which is a white line that divides the head into 2 symmetrical zones. And you have the choroid plexus, which is appearing as these white patches on either side of the calvarium. And this evaluation of the head is complete only when you go and evaluate the baby in the sagittal plane from the transverse plane. And in this, we follow an anatomical approach where we look at some black and white spaces. We see 1, 2, 3, and 4. 1, 2, 3, and 4. We try to look at the presence of these 4 black spaces inside the brain of the baby when the baby is showing the face. We use this image to look at the nuchal measurement each time, but we simply have to add on to the fact that you go inside the brain and look at the presence of these 4 black spaces. And if these 4 black spaces are there and you have seen the calvarium and the fox, you have ruled out major CNS malformations at 12 weeks. To look at the face, once you have seen the face profile, just simple rotation of the probe, we see the 2 eyeballs and we look at this structure called the maxillary triangle. And this maxillary triangle rules out major degrees of clefts of the palate. Point to note, all kinds of facial clefts can be ruled out at this time. Some of the major clefts and bilateral clefts, yes, can be made out. From the head and the face, we move down. We've already had a brief on the cardiac assessment. We have to look at the symmetrical lung fields on either side and the cardiac inflows and the arches. And this can be visualized much better at 13 weeks and much better by a transvaginal scan in most babies. And an extended cardiac assessment at this point of time would help rule out major structural malformations of the heart, which I think would be dealt with in the next talk. We don't move down to the abdomen. In the abdomen, again, image the abdomen in 2 planes. This is a coronal plane and this is a transverse plane. In the coronal plane, you look at the 2 black spaces, which is the stomach and the bladder. Interspersed between that is a white bowel. And in the coronal plane, you can see this is by a transvaginal scan. A transvaginal scan is so much better. You're able to see the anatomy more sharply. And in the transverse plane, you look at the cord insertion site into the abdomen. Switch on the color Doppler, you can see the 3-vessel umbilical cord. So once you go from the chest to the abdomen, make sure you assess the abdomen in the coronal plane and you assess the abdomen in the transverse plane. Very simple sweeps, much easier to see by the transvaginal scan. Again, you go by a black and white approach, 2 black spaces, which is the stomach and the bladder, and the white, which is the bowel interspersed in between. So once you have done this, sometimes you may not be able to see the stomach or the bladder, especially in babies which are sub 12 weeks. Don't panic. We just have to wait for a couple of hours or in a few days time. If it's still not seen, then these pregnancies need to be called a little early at 16 weeks for early anomaly scan. Imaging is not complete in the abdomen unless you finish the KUB imaging. By a transvaginal scan, especially in 13 weeks babies, you're not only able to see the stomach, you're able to see the kidneys of the babies also. Point to note, a lot of pitfalls will be there to assess the kidneys. Focus on presence or absence of the urinary bladder alone at this point of time. If you're able to see the kidneys also by a transvaginal scan, that's an extra bonus indeed. And that anatomy is complete by evaluation of the extremities. And extremity evaluation means we assess the 3 segments, that is the 2 limbs, the upper arm, elbow, forearm, and hand, and similarly the legs. We will be able to see the movements at all joints. Very, very important. Flexion, extension actively must be seen, and the opening of the hands and the feet in the coronal plane can also be imaged. And once you are done with that, we complete it with the imaging of the spine. Spine assessment is done again in the sagittal plane. You can see it's better in the transvaginal scan, and spine is always better seen once you go to close to a 13+ weeks baby. So the main factor which assess the visualization of the anatomy at 12 weeks is the crown to rump length. Smaller baby, difficult to see. After 60, anatomy is much, much better to see. You complete the anatomical assessment by looking at some of the markers for aneuploidy, and these are the nuchal fluid measurement, the presence of the nasal bone, and the presence of some of the aneuploidy markers. And these will be dealt with in the further talks, which are the ductus venosus and the tricuspid regurgitation. I will complete this talk by the completion of the anatomy assessment, and in multiple pregnancy, the assessment is complete only if you make a document of the chorionicity of the baby, and this chorionicity is assessed by the location of the placenta, which is the single or double placenta, or the presence of your classical twin peak or the T signs to assess the chorionicity. And we date the pregnancy in the first trimester at the end of the anatomy assessment, depending upon whether it's an IVF pregnancy or a natural pregnancy. If it's an IVF pregnancy, use the embryo transfer date. If it's a natural pregnancy in twins, you use the CRL of the larger twin. So to conclude this talk, a targeted imaging of the anatomy with the rule of 2 checklist can be done in the first trimester. Challenges are there. Anatomical planes are difficult to image because of the fetal position. But by using transvaginal imaging, checklist, patience, and a constant process of audit, you can raise the bar and make sure that you achieve the best possible evaluation as early as this point of time. Thank you so much.
Thank you, sir. The talk was very informative. I'm sure everyone benefited from it. Thank you so much for joining us today.
Thank you.
I request our Professor Dr. Rohini ma'am to say a few words.
Thank you. Thank you, Dr. Sudarshan. That was, as usual, a very, very crisp and very illustrative demonstration of the first trimester scan. And as you have said, transvaginal ultrasound is a must nowadays for first trimester scan. You said that nowadays NT scan alone is not enough and we need to go into a detailed scan. So the routine ultrasound being done in many centers are reporting only on NT. They don't do the targeted scan, which they postpone till the 19 to 20 weeks. So what would you, what would be your message for?
I think that was the introduction of my talk, was that we should stop giving in the referral slip, kindly do NT scan. The referral slip must change first. Whenever any clinician sends a patient for 12 weeks, don't write in the request slip, do NT scan. It must be do a first trimester evaluation and screening for aneuploidy. So that what will be the best way to do it, I would say. Change the referral slip and ask for more, you will get more.
Thank you.
Thank you. Thank you, ma'am. Our next session is on the role and limitations of ultrasound detection of first trimester fetal abnormalities by Dr. Malati Prasad. I request Dr. Rohini ma'am, our professor and chief of Department of Obstetrics and Gynaecology, Savita Medical College, to introduce our next speaker. Professor Rohini ma'am is a professor and chief of Department of Obstetrics and Gynaecology at Savita Medical College. She did her undergraduate and postgraduate from Gandhi Medical College, Bhopal. More than 25 years of experience teaching undergraduate and postgraduate students, has published many papers in reputed journals, was also the co-author of Foxy Focus of PG book. She is a very good mentor, leader, and an inspiring personality. Thank you for joining us today, ma'am.
Thank you, Evangeline. Can I have Dr. Malati's CV, please?
That's fine, ma'am. I think we'll start.
Just 2 minutes, madam. Yeah. It's our privilege to introduce Dr. Malati Prasad. She's a well-known personality in the fetal medicine units across the country and abroad. She is an MD with MRCOG and a diplomat of the National Board. She is presently the director of Trichy Fetal Medicine and Fertility Center, and she's won the first prize for paper on fetoscopic skin biopsy in epidermolysis bullosa in National Conference Induction 2011. She also won a Best Paper Prize at UOFOXY 2015 for the paper on alpha thalassemia and non-immune hydrops. Consultant in maternal and fetal medicine at Trichy, and she has a certification for the first trimester ultrasound. She has held the post of Secretary Trichy Ob-Gyn Society and an executive member of the Imaging AR Medicine Committee of the FOGSI 2019 to 22. She is also the Vice President of Trichy Ob-Gyn Society, and she's a member of the ANRCOG, FOGSI, IMA, and is an invited faculty in AICOG and UOFOXY. Thank you, Dr. Malati.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am. Thank you. Thank you very much for the kind introduction, ma'am. Are you able to hear me now?
Yes, we can see your slides.
After Dr. Sudarshan's topic, I think my job has become easier because I'm just going to rush through the first trimester checklist for fetal abnormalities and what all you can detect in the first trimester. And the first and foremost, accurate information, which is very important because it will help you to take decisions regarding the optimized antenatal care. It will help you to detect the gross fetal abnormalities so that the patients can take decisions regarding termination. It also helps you to assess prognosis in future pregnancies. So first and foremost, as already said, you have to assess the viability, establish the gestational age accurately, determine the number of fetuses, especially in twins. And if it is at 12 weeks, you must assess the chorionicity, document it in your image, and look for fetal abnormalities, gross fetal abnormalities. So let's rush and see what all you can see. So this is done between 11 to 30 years. You need to do a complete CRL in a mid-sagittal view, which is what precise of 5 days in 95% of cases. And CRL, if it is more than 84, head circumference can be used to date the pregnancy if the patient is not sure of the dates. So first and foremost is that what we do, the first measurement we would do in a first trimester ultrasound is a biparietal diameter and head circumference. The biparietal diameter is the largest true symmetrical axial view of the fetal head, where you can see the third ventricle, the interhemispheric fissure, and choroid plexus. So if you do not see this butterfly sign in a first trimester skull, you're in trouble. You have to think of a holoprosencephaly. So that is the first and foremost message which I would like to tell all of you. Always put a transvaginal ultrasound. Look at the head, look for the butterfly sign. If you do not see the butterfly sign, it is probably a lobar or a semilobar holoprosencephaly. And BPD measurement should be done from outer to inner to outer to outer. There are many guidelines stating different but ideally I think we stick to outer to inner. So first and foremost, what is the advantage of early screening? We always say that let us do it first. Let us do it in the first trimester because helps you to detect and exclude major anomalies. Early reassurance to at-risk mothers, especially the woman has had a previous anencephaly. She's very, sort of apprehensive to know whether the fetus is fine at this pregnancy. Earlier genetic diagnosis, and if you find that there is a gross lethal anomaly, it's easy to terminate pregnancy at 12 weeks rather than taking up to 20 weeks of gestation. But limitations, once again, you have to be trained. There's an uncertain cost-benefit ratio and some late development of anatomic structures like corpus callosum, hypoplastic left heart cannot maybe be seen in the first trimester of pregnancy. Especially CC cannot be seen, and you cannot actually, you're not supposed to look. You can look at the cerebellum, but you have to document it once again at 16 and 20 weeks of gestation. Especially the CNS abnormalities are better seen at 20 weeks of gestation rather than the first trimester. So first and foremost, the crown length. I'm not getting into details of doing a nuchal translucency. Always do a nuchal translucency. Look at the nasal bone and biparietal diameter and the nasal bone. These are the 4 measurements which you need to do in the first trimester of pregnancy. So as per our paper by Nicoloids for diagnosis of fetal non-chromosomal abnormalities at 11 to 13 weeks, it was found that in the first trimester, they picked up 27.6% of anomalies. The second trimester, they picked up 53.9% of abnormalities. And the third trimester, they picked up 14%. And something which went undetected, which was detected after birth, was 5%. So we have a real good margin, about 30%, where you can actually diagnose in the first trimester of pregnancy. Actually, when I presented a similar thing in Cochin, they asked me, how long does it take for you to do a complete genetic sonogram the first trimester? I said, it takes about 20 to 30 minutes, depending on the position of the patient. So you should have the patience and tolerance to look at the fetus for at least 30 minutes for the first trimester anomaly detection. So what is accuracy? As per 19 studies, 78,000 pregnancies, the detection rate is almost 51%. So if you do a proper first trimester anomaly scan, detection rate is 51%, and cardiac defects can be picked up to the extent of 53%. So it's important to get trained in doing a first trimester ultrasound so that you can pick up early abnormalities and you can prognosticate the pregnancy. So first and foremost is the head. You have to look at the cranial bone ossification at by 11 weeks. And you will see ventricles which are filled with the choroid plexus in their posterior 2/3. If you do not find the choroid plexus should go up to the lateral margin of the ventricles. If you do not find it going up to the lateral margin, you have to think of ventriculomegaly, and the cranial wall should be clearly seen. If you don't find the cranial wall, think of anencephaly. There should be no bony defects. And as again and again, a butterfly sign is very, very important in the first trimester. If you don't see it, think of a lobar or lobar holoprosencephaly. And hemispheres, as you see, should be symmetrical and should be divided by an interhemispheric fissure. And if you do not find an interhemispheric fissure, again think of a lobar or semilobar holoprosencephaly. The brain mantle is very thin and best will be seen anteriorly rather than posteriorly. And corpus callosum and cerebellum may not be assessed in the first trimester. As you saw in the previous slide, you clearly saw the butterfly sign, whereas in the next slide, which is holoprosencephaly, there is no butterfly sign at all. You find a monoventricle. This was a case of holoprosencephaly, tested trisomy 13 by CVS, and she went for termination of pregnancy. And what are the different planes that you would see? For example, we always been thinking about bilateral diameter, axial plane, coronal, and sagittal of the head in the second trimester, but these planes should be taken in the first trimester of pregnancy. One is the transcerebellar, transthalamic, and the transventricular. See, in a second trimester, normally we do a transthalamic, transcerebellar, transventricular. Same way, you must do all these three planes in the first trimester of pregnancy. In a transventricle, you will find the choroid plexus along with the ventricles on either side. You will see the thalamus with third ventricle, and you can see the aqueduct of Sylvius will be seen here. There's a third ventricle. You find a cone with fourth ventricle here. In a this is a transcerebellar plane where you find the developing cerebellum and the fourth ventricle. Sometimes you may find a dilated fourth ventricle. Then you think of, sometimes when you follow the patient of these with dilated fourth ventricle at 16 weeks, you will find a Dandy-Walker malformation. The transthalamic is important. You will see the forks and two thalami on either side. Now, transventricular, as I said, you will see the interhemispheric fissure and two choroid plexus and the ventricles. And the choroid plexus should almost fill up the ventricles. If you find that they're not extending up to the lateral 1/3, think of a ventriculomegaly. So this is a small video clipping of transventricular plane of the axial head. So many of seen as anomalies as per Nicolaides and other groups can be picked up in the first trimester. Do it very, very carefully. So this is a third ventricle which you see here. There's a thalamus on either side. You find the third ventricle here. The third ventricle is clearly seen. If you find a dilated third ventricle, you can follow the pregnancy at 16 weeks to look for ventriculomegaly. Transcerebellar, you find the developing cerebellum and the fourth ventricle. So what are the abnormalities which you can see in the first trimester? The first and foremost is anencephaly, which never ever should be missed in the first trimester. When you put a transvaginal ultrasound, you'll find a hyperechogenic amniotic fluid. Can you see the hyperechogenic amniotic fluid here? This is looking normal. Whereas here you find an hyperechogenic amniotic fluid, which is typically seen in acrania and anencephaly. And encephalocele also should be seen. This was a case of encephalocele parieto-occipital, which is seen in the first trimester. Patient opted for termination of pregnancy. So when you measure the BPD, what are the features of holoprosencephaly in the first trimester? When the bilateral diameter is less than the 5th centile, when you find this is a normal, as I said, butterfly sign, interhemispheric fissure. Here, this is a case of holoprosencephaly where you don't find the thalami, it's a fused thalami monoventricle. There's a complete loss of butterfly sign. The next thing is to look for the intracranial translucency. When you find an obligatory intracranial translucency, you have to think of a spinal bifida. This patient, this is a normal intracranial, this is a brainstem, intracranial translucency, and the occipital bone. Here, this is a case where if you see the intracranial translucency is completely obliterated, and when we had a look at the spine, we found a small meningocele at 12 weeks of gestation. So we don't have to wait for the Arnold-Chiari malformation to occur at 16 to 20 weeks. This can be picked up in the first trimester. When you do not find an intracranial translucency, have a thorough look at the spine, you will find a meningocele there. So next, you have to go to the eyes, look at the eyes. The lenses can be seen in the first trimester. Measure the interorbital distance, binocular distance. If the hypertelorism is that increased interorbital distance is more than 95th centile, think of trisomy 13, 18, 21, and Apert and Carpenter syndrome. Hypotelorism is that when it is less than the 5th centile. This is done with the software. The centile is done with the software. So whenever we think of hypotelorism, again, counsel the patient for invasive procedures. So coming to the face, a complete sagittal section of the face is important. Look at the palate. You should find the superimposed line sign, as you can see here. If you do not find the superimposed line sign, think of defective palate or palatal abnormalities. Look at the nasal bone. You'll find the equal sign, tip of the nasal bone, and you have to look at the mandible. The mandible and the maxilla should be parallel to each other, and the mandible should reach up to anterior 2/3 of the maxilla. Then coming to the face, lips, you will have a good look at the lips. You don't have to actually document. If you find a suspicious cleft lip, call it back at 16 weeks, look at the lips again. And you must see a complete premaxillary triangle. A triangle should be seen. If there is a defect in the basal portion of the premaxillary triangle, think of a palatal abnormality. This was a case of micrognathia, picked up a first trimester of pregnancy, and the patient went for termination. So have a good look at the face. When you turn the probe, you will find the section of the face, and you'll always see the PMT. If you do not find the PMT, if the PMT is open, think of either the nasal bones are absent or the basal triangle is absent. You have to think of a palatal abnormality, a primary palatal abnormalities. This was a facial mass which is picked up at the first trimester of pregnancy. As you can see, it's an oropharyngeal mass. The patient tested for histopathology as a mucinous duct papilloma, and they went for termination of pregnancy. Now coming to the neck. Neck is where you'll find a huge cystic hygroma here, the huge cystic hygroma. All these patients or these pictures which I've posted, all of them tested positive. One was tested positive for the mosaic Downs. The fish was normal, but the karyotyping was mosaic Downs. This patient tested showed Turner syndrome. If you find a huge cystic hygroma, especially with the hydrops, then definitely the likelihood of chromosomal abnormalities is very, very high. Look for bilateral jugular lymphatic sacs, and the proper alignment of the neck and the trunk is very important, because the star gazing could be suggestive of leniencephalite. Coming to the chest, the lungs should be of homogeneity. You should find the ribs, which is normal in length and shape, and look for any pleural effusion. There's a case of pleural effusion here. And you can see the homogeneous lungs there, and you can see the extent to the diaphragm. A diaphragm continuity should be established in all cases. Always put a picture or image of diaphragmatic continuity. If you find the stomach bubble above the diaphragm, think of early diaphragmatic hernia. And normal position of the heart is very, very important. Access the cardiac regular activity. You should see a 4-chamber view. This is a 4-chamber view of the heart with a good color flow. You can see the inflows, and you can see a V there. Then your rest is showed that the 4-chamber view and the outflow tracks are absolutely normal. The arches are completely normal. So this was a case. So always make sure that the establish a situs. Make sure the heart and the stomach are on the same side. Establish first the left and right of the baby, and then make sure that the stomach and the heart are on the same side of the fetus. This was a case of hypoplastic left heart, no flow at all through the left ventricle, a single outflow tract. You can see a complete narrowing of the aorta, and she also showed reverse flow in the ductus venosus. Coming to the spine should be seen in two views. That is, as you would see in a second trimester scan, the sagittal and the coronal view. In a sagittal view, have a complete look at the dorsal spine and the anterior spine, and make sure that the skin is intact. This can be very, very clearly seen even in the first trimester. Have a good coronal view. A coronal view will give you, you'll be able to pick up small meningocele in a coronal view. Because as far I've seen that whenever you find a splaying of the bones in the first trimester, you have to think of a small meningocele there, or you could have a spina bifida. So always a coronal view is very, very important. Do not miss out the coronal view. And when you have a meningocele, remember that the bipedal diameter is always less than the 5th center. So this was a small meningocele which was picked up in the first trimester of pregnancy. It was almost stuck to the uterine wall. We had to wait for almost 10-15 minutes for the baby to move. And this the meningocele which is seen there. And generally in the first trimester, the lemon and the banana sign is absent. You may have a crash sign where you find the cerebellar peduncles across just stuck to the occiput, which is called the crash sign. This was a case of an acute kyphoscoliosis which is picked up in the first trimester of pregnancy, and this patient actually tested positive for trisomy 18, and she went for termination of pregnancy. You can see the kyphoscoliosis there, which was seen at first, and she had a cystic hygroma, and CVS was offered for this patient. The cranium was absolutely normal in this patient, but his spine showed a kyphoscoliosis. So do not forget to look at the spine in all cases in the first trimester of pregnancy. So crash sign is displacement of mesenchyphallon against occiput. When you find an obliterated intracranial transfer, you think of spinal bifida. shortened cisterna magna. Diagnosis may be difficult due to small lesions. If you have a suspicion, call her again at 16 weeks of pregnancy to have a good look of the spine. You can see the IT completely obliterated here, and you will find a meningocele there. Lemon and banana sign is generally absent in the first trimester. Coming to the abdomen and pelvis, make sure you find the stomach below the diaphragm. You will find the kidneys, the mid abdomen, and the lower abdomen. In the upper abdomen, you'll see a left-sided stomach there. You can see the right-sided liver, the descending aorta, and the IVC, and you can also see the umbilical vein, which is the plain one. In the mid abdomen, make sure you do the cord insertion. Normal cord insertion should be demonstrated, so you can be rest assured that there's an intact abdomen wall. There should be no ascites. This was a case of oncology which is picked up in the first trimester, and patient went for termination of pregnancy. The lower abdomen, once again, you must have a good look at the bladder. As Dr. Sudarshan said, if we're not able to see the bladder, don't panic. Call her back after 2 weeks. We'll definitely see the bladder after 2 weeks, as long as she's got 2 kidneys. Actually, you can see the kidneys also in the first trimester, and demonstrate 2 umbilical arteries on either side when you find that. And you can also demonstrate the renal arteries, signifying that the kidney is present. So fetal kidney should always be in a paraspinal position as bean-shaped echogenic areas. If a fetal bladder should be visible as a hypoechoic area. So this was a case of pelvic ulcer separation, which is picked up in the first trimester of pregnancy. And if you're not very sure of the kidneys, when you apply color Doppler, you can see the renal arteries. And still not sure, call her back after 2 weeks. You will have a good look at the kidneys. So this was a polycystic kidney, which is picked up in the first trimester of pregnancy. It was the case of Meckel-Gruber syndrome. The patient actually, the first baby had Meckel-Gruber syndrome. The patient did not have any exome sequencing. So again, she presented with Meckel-Gruber syndrome with polycystic kidneys. And we did a CVS and confirmed the Meckel-Gruber syndrome. The patient is now planning for a next pregnancy through PGS. So bilateral hydronephrosis can be demonstrated. This is a low, very refined descendant bladder more than 7 millimeters with the keyhole sign with bilateral hydronephrosis. Normal orientation of the 2 hands and feet, the 3 segments of the leg and hands should be seen to look at the toes and the fingers in the first trimester of pregnancy. And if you're not sure of the orientation, sometimes you may misdiagnose a cleft palate because of the orientation. Call her again at 16 weeks to once again confirm if you have any clubfoot-like abnormalities. So this was a case of very short femur, which tested positive for skeletal dysplasia. You can hardly see the femur there. So this is a normal orientation of the foot, and you can find a clubfoot here. This patient who had a short femur also had a clubfoot, bilateral clubfoot on either side. So as you can see beautifully, even in the first trimester, you can diagnose a clubfoot, you can diagnose short limbs. And the femur length is one measurement which should be taken along with a bipedal diameter and head circumference. So what all is, you can see in the, you should have a checklist. That is head, you should see the cranial bones and midline folds, choroid plexus, neck should be normal, nuchal translucence should be measured, eyes with the lens, nasal bone, normal profile should be seen, intact lips should be seen, spine, look at the vertebra, intact overlying skin, in the chest there should be no effusions, heart, cardiac regular activity, abdomen, stomach, bladder and kidneys should definitely be seen. Look for normal cord insertion. There should be no umbilical defects. Extremities should be seen in detail, and look at the cord for 3-vessel cord. So always safety, lowest possible power output, BM and M mode is safe, Doppler's greater energy output and therefore more potential bioeffects. So some things which you cannot actually see in the first trimester is the corpus callosum. Sometimes the hypoplastic left heart and right heart cannot be seen in the first trimester of pregnancy. So to conclude, I think, have I gone beyond my time? Conclude, a detailed first trimester ultrasound checklist is mandatory with documentation, and it should not replace the targeted anomaly scan. Even if you've done a first trimester thorough anomaly scan, call her again as for your usual 19 to 20 weeks anomaly scan for targeted anomaly scan. When in suspicion of anomaly, always get a second opinion. Do not offer termination based on that. Ask for a fetal medicine specialist opinion, and then termination can be considered as an always. Thank you. Thank you very much for your patient hearing.
Thank you, Dr. Marathi. They were just absolutely wonderful slides, very clear pictures. Thank you for sharing all those anomalies, which made the point very clear.
Thank
Actually,
you.
I had one case of first trimester truncus cardiomegaly today morning, but I didn't have time to upload the video. So it was a first trimester ultrasound, came with cardiomegaly, VSD, and a truncus arteriosus, and we could easily pick it up in the first trimester of pregnancy. So many almost 50% of cardiac defects can be picked up in the first trimester of pregnancy.
So you would say that any gross anomalies, we can go in for termination in the first trimester itself based on the first trimester scanning. But
Yes, ma'am. Yes, ma'am.
yeah, and then we don't even have to go in for the biomarkers and
Yes.
the biochemistry. There may be certain situations which biochemistry may add on, and then the second trimester scan.
So based on the anomaly, we can always offer an invasive testing. Suppose you find that the anomaly suggests to have trisomy 13, 18, or 21, then we can offer invasive testing for documentation so that we can prognosticate future pregnancies.
So we need not go in for the biochemical markers and go directly for the invasive. When you have
Yes,
a very prominent structural defect.
Yeah.
Thank you, Malati, for the very nice lecture.
Thank you, ma'am.
One thing, I want the students to know that always a sign, whenever we say sign, it means a pathognomonic thing. And it indicates a pathology. But you have mentioned about the crush sign, lemon sign, banana sign, and butterfly sign. But out of which, butterfly sign is a good sign. People should not mistake it. Yes, please have it in.
Actually, I've taken classes for the students. I've emphasized that look at the butterfly sign in all patients. Put it your transvaginal ultrasound, look at the butterfly sign. You will never miss an anencephaly or a holoprosencephaly.
Yeah. Thank you. Thank you so much.
Thank you, ma'am. Thank you very much. Thank you.
Thank you, Malati ma'am. Thank you, Rohini ma'am. Thank you, Jayashree ma'am. Our next session for today will be Thick NT What Next by Dr. Deepti Jami ma'am. I invite our Professor Dr. Shanti ma'am to introduce and share this presentation.
Good afternoon, one and all. Thank you, Dr. Vansilin. First, I would like to thank Professor Hepzibah ma'am for giving me the opportunity to chair the session. So after listening to the enlightening talk by Dr. Sudarshan and Dr. Malati Prasad ma'am, we have our eminent speaker, Dr. Deepti Jami, to enlighten us about what is to be done next when thick NT is detected. So I'm happy to introduce her. Dr. Deepti Jami. She's a postdoctoral fellowship in fetal medicine, Tamil Nadu, Dr. MGR University, and she has had a fellowship advanced OBGYN ultrasound at Mediscan. And she has work experience. She's the director and fetal medicine consultant at Chennai Women's Clinic and Scan Center, fetal medicine consultant at Apollo Cradle, fetal medicine consultant at Anuradha Maternity Center. She has received many awards for the best oral presentation at INSUOG at New Delhi 2015, an award for best poster presentation in 2015. She has had her gold medal for best oral presentation at US Con Mumbai 2015, gold medal in forensic medicine in 2003, and so on. So as we all know, she's the best outgoing student in 2006. A warm welcome, madam.
Thank you so much. Thank you so much. The kind introduction. I hope I'm audible.
Yes, madam.
I would like to extend my thanks to Hepzibah ma'am and Jayashree ma'am for this wonderful opportunity. It's always a pleasure to be a part of Savita Medical College, the entire team and the fetal medicine department. I think the previous two speakers have laid the foundation pretty strong. We're very, very clear as to what we can see in our first trimester ultrasound, what we can report, what we can diagnose, how we need to talk to the patient. So I think what next we need to know is thick, raised, increased nuchal translucency, because that's where all of us are stuck in the first trimester, because first trimester is a very, very tricky phase. If it's going to be the anomaly scan period where in 19 to 20 weeks time, okay, so you very well know the baby is quite sizable, you know, you can diagnose anomalies, you'll be able to talk to them. But during the first trimester, the fetus is hardly around 5 to 6 centimeters or so, around 12 weeks. At the same time, you see umpty number of structures, like how the previous two speakers have already spoken. So when you see those structures and when you identify an abnormality in one of the main thing, which is a nuchal translucency, we're all done. With the thing is, when it is associated with other abnormalities, we know what we need to do. But if it's going to be only a raised or an increased nuchal translucency alone as an isolated marker, where do we go about, or what do we do? So for that, we need to see three things, right? For the next over probably 10 to 12 minutes, we're going to discuss these three main aspects. What is the criteria for raised NT? So how do we actually define for the fetus, the NT is raised? That's the first point we need to know. As students, as clinicians, as fetal medicine consultant, that's what we need to know first. That's number one. Number two, once you find out an increased NT, whether it is associated anomalies or isolated, how do you go about counseling the couple? And more so if your NT is an isolated increased level. And after which, all these years throughout our training, we've always been told increased NT equates to chromosomal abnormalities. Absolutely true. But is it all what we see? Is it only chromosomal abnormalities? What do we do if you have an isolated increased NT and your karyotype comes normal? So that's the question which we need to answer right now. So these three main questions are what we're going to see over the next 10 minutes. So there has been a complete around probably close to 80,000 euploid fetuses, where in this graph, you'll be able to see they have measured an NT across the various gestational age. So this normal value is available. One is available free of cost in our software, in FMF sites, and also in our pathogram books, or in all our obstetric gynecology books. We have a CRL which is correlated with that of the NT. So what we need to know beyond that is, apart from the CRL getting correlated to NT, then what we need to know is how good our CRL and NT images should be. So that's very, very important, because you're going to rely on a measurement which is going to be based on another measurement. So when you start with the CRL, it always has to be a mid-sagittal section, that's for the NT, and also a neutral position for the CRL. So what is the CRL? It's from crown to the rump. So from the crown to the rump, it has to be a neutral position, baby lying down neutrally, and from outer to outer margin is what you're going to measure. So there should be a space between the chin and the chest. And also, when you measure nuchal translucency, it has to be the head and neck, and along with a part of the thorax, which is more than 70% occupying the screen. Because all these things are, how much ever we see that these are very, very crucial, because they play a huge role in interpreting our findings. So nowadays, we do have automated NT measurements, because we do have our machines which are automated to provide us NT value to avoid errors. If not, we need to do our NT manually or automated. So anywhere it is fine, but usually if you find an NT which is raised, it's always good practice to measure 3 or 4 times and take the mean value. So I was talking about NT image audit. Why audit? Why do we need to know the structures? Because knowing the structures is very important, and only then you can rely on the nuchal translucency. Why measure NT at all? Why do we need to know NT? One, if the NT is raised, we need to rule out other structural anomalies in the fetus. Even though we'll be doing all our rules or we have the checklist to rule out the other abnormalities, it's very crucial when we find an increased NT to make sure that structurally the rest of the baby is fine. Then following which, you need to decide on which diagnostic test to do. Whether will you be offering a direct invasive testing or an NIPT? That's a huge question mark, one more day, because the NIPT has come a long way. It's been more than a decade since we've had NIPT with us. And it does show a pointer towards our genetic counseling, because our entire counseling changes when you find a fetus with increased NT. It provides good load of information on talk to the parents about the postnatal outcome of such fetuses. So it's very crucial for us to know what are the structures we are dealing here with increased NT or in an NT image before we call it as increased NT. So we have a mid-sag section, we have the nasal bone over here, the palate, the mandible, then this is the part of the diencephalon. Then what you need to see, we've already been told these structures, that these are the brainstem, the intracranial translucency or the fourth ventricle, the cisterna magna, and below which is the occipital bone, and the NT is a layer which is closer to the occipital bone. Below the NT, there'll be an amniotic membrane. There are many, many times where we've had, even now we do get patients with second opinions for increased NT, where the NT has been measured, including the amniotic membrane. You need to hold on for the fetus to jump up and down and actually see the NT, which is closer to the occipital bone, and not measure along the amniotic membrane. Then there has been a huge level of confusion. How do you define increased NT? Is it 3 millimeter? Is it 3.5 millimeter? Is it 95th centile? Or is it 99th centile? Umpty number of values and ratios we have to define increased NT. Different bodies, different definitions. But ISHWAG has remained silent in this. ISHWAG is International Society of Ultrasound and OG, where they have not particularly kept a protocol for increased NT. According to Fetal Medicine Foundation, NT more than 3.5 is considered increased. According to ACOG, anything an NT more than 3 millimeter, and Society of Fetal Medicine, here or there, no longer more than 99 centimeter. So invariably, let me put this confusion into one place. When the CRL is above 5 centimeters, that's around 5.5 to 6 centimeters or above, your NT value of about 3.5 falls at 99 centile. That's above 5.5 to 6 centimeter. Then what do you do when the NT is between 4.5, 5 or less than 6 centimeter? Then you have taken, you can probably take a cutoff of 3 millimeter. So this is where we have found. So anywhere above 3 millimeter when there is around 11 to 12 weeks. And if it is less than 11 weeks, we will see in the last few slides what to do. So 3 to 3.5, yes, it's borderline NT, above 95 to 99 centile, above 3.5, it's more than 99 centile. So anywhere above 3, your antennas are up, and you need to make sure that you see you thoroughly scan the fetus structurally completely. So then why are we concerned about raised NT when everything else is normal? Raised NT, as we all know, no doubt at all, it does hold a high risk of chromosomal aneuploidies. Beyond chromosomal abnormalities, we are now testing even for pathogenic copy number variants. You have good load of single gene disorders which show up in baby as increased NT, and of course structural abnormalities. When you talk about structural abnormalities, the most common structure which gets involved in a raised NT is cardiac. More time on over again, cardiac abnormalities. Yes, we do get a good view of imaging of the heart because we have good load of ultrasound machines with good resolution nowadays, and also a good amount of use of transvaginal ultrasound improves the quality of how we see the fetal heart. At least we get to know the reason to a larger extent why the NT is high. In microdeletions, the pathogenic copy number variant, the most commonly encountered is 22q microdeletion. That's called bilocardial facial defect. That's also associated mostly with a cardiac abnormality or outflow tract abnormality. In single gene disorders, not to forget, an isolated increased NT could point, Noonan syndrome should be in the back of our mind. And other chromosomal abnormalities, many a times we do end up with seeing triploidy. These common things are apart from our routine chromosomal abnormalities like trisomy 21, 13, and 18. So then we have already seen there's quite a number of association with chromosomal defects and bad obstetric history. As you can see here, it is no brainer that we know when the NT is less than the 95th centile, where it is less than 3 mm, or say it's 2 or 2.5 or 1 or 1.5 millimeter, we find that the majority of the babies, around 97% of them, are alive and well. So that's more reassuring. Whereas when the NT goes beyond 3.5, you can see a drastic change from almost 70% alive to it goes up to down to 50-50. There's almost half of the babies when it goes beyond 4 to 4.5, you can find out that 50% of those babies are going to have an issue, or 50% are going to be alive. So it's no pain where we know that the bad obstetric history increases and chromosomal abnormality increases as the NT value increases. Number one, beyond aneuploidy, as the increases around 4.5 to 6.5 millimeter, is 60 to 70% of aneuploidy risk. And what else do you need to know about skeletal dysplasias, congenital cardiac malformations, genetic syndromes, and overall around 30% of adverse pregnancy outcome. So then what else do we need to know when we find increased NT? Do we have a checklist? Can we draw a flow chart? Yes, this is a basic flow chart everyone needs to have in mind, or everyone needs to know. Once we find a fetus with increased NT, the first thing we need to do is see the rest of the fetus. Again, rule out the entire anatomy of the fetus, have a checklist. See the other aneuploidy markers, nasal bone, ductus, tricuspid regurgitation, rest of the fetal anatomy. And apart from that, initially when we started, probably if you would have asked me to present this slide, like even 7 years, 8 years earlier, I would have stuck to karyotype and QF-PCR or FISH. But now beyond karyotype, we are going in for microarray, we are going in for genomic sequencing, whole exome sequencing, and rasopathy. We will see what are the additional advantages of doing those testing. So a checklist definitely, and that too if it is an isolated increased NT, rest of the fetal anatomy as early as 12 to 13 weeks, and do not forget to call the patient back on an early target scan. You do not want to push the fetus up till 19 to 20 weeks because our decision-making capacity becomes very limited at that point of time. Anywhere between 16 to 18 weeks is an ideal time to get the patient back. Talking about chromosomal abnormalities, we all know there are typical and atypical errors in chromosomes. So typical errors, we would say around trisomy 13, 18, and 21. That's what we screen for. That's what we do in our first trimester screening. And along with that, there could be a possibility of sex chromosomal abnormality. Then what are atypical errors in chromosomal abnormalities? Those are called pathogenic copy number variants or autosomal chromosomes which are involved in trisomies, unbalanced translocations, or mosaic. So then when we see an NT, which is less than 3 millimeters, somewhere between 1.5 to 2, then the percentage of those fetuses having typical or atypical chromosomal abnormality is very, very less, hardly like 0.2 or 0.1%. But when the NT increases to 3 to 3.5 millimeter, you can basically make out that the typical and the atypical chromosomal abnormalities increases significantly. So when the typical chromosomal abnormalities is around 3.9% when they increased NT, and atypical abnormalities is somewhere around 0.4 to 0.5%. But significantly it increases when your NT value is beyond 3.5 millimeter. So when you say 3.5 millimeter, the number of typical abnormalities, that is when you find a trisomy 13, 18, or 21 is around close to 30%, and the atypical chromosome abnormality close to 5%. So as exponentially the NT increases, you are going to find out more and more chromosomal abnormalities. And why beyond KT? What's there beyond karyotype? The routine karyotype, all of us know we need to make sure that we get it done. But do we get to gain by doing another extra additional test in the same CVS sample or in an amniotic fluid? Yes, we do. That's called chromosomal microarray. And what does this chromosomal microarray do? It goes in-depth analysis of your chromosomes, and the yield of these are one of the few articles, recent articles, which I was able to pull it out during for a chromosomal microarray, where you can actually see that close to 5 to 6% of an increased yield you can get in fetuses with isolated increased NT. So when you have isolated increased NT, beyond a karyotype, if you want to rule out even more, I think nowadays this is opted as the first line of evaluation. Yes, always karyotype has been there, but chromosomal microarray has slowly taken over its position, come across over there a karyotype. So it yields around 5 to 6% extra knowledge about our chromosomal and pathogenic copy number variants. Then what are we to do when repeatedly recurrent, when the fetus is having increased NT? You have done a karyotype, which is normal. You have done a microarray, which is normal. And the patient comes to you and asks, is there anything else, doctor? Why do I even repeatedly get increased NT? Where you have tested everything. You said everything is normal. My chromosomes are normal. Is there anything extra that can even identify? Yes, we do. We do have rasopathy genes. So these genes are actually, rasopathy is a part of a protein signaling pathway where there are close to around approximately 20 genes, which will be covered in the rasopathy panel. And one of the most important, that's almost 50% of the rasopathy panel, the fetuses are involved with the Noonan syndrome. So if you encounter an isolated increased NT, say around 4 millimeter or 4.5 millimeter, where the rest of the baby is perfectly normal, and this patient or the fetus has already had a KT and a CMA, or previous babies, the patient has had terminations for increased NT and they've already performed a karyotype, which is normal, then probably you could think of a Noonan syndrome, where you can opt for this rasopathy gene testing, the panel, so that we definitely could have a better yield for that patient. And not that yet, we do have, in spite of rasopathy gene, and apart from that, if you want to check for recurrent probably recurrent increased NT fetuses, or for a couple who have recurrent increased NT, then we do probably the yield of a whole exome sequencing, that's from the fetal DNA, if possible from a chorionic villus sampling, where we get good load of DNA from them. When compared to amniocentesis, the yield is approximately 3, and in one study, or into 2019 in CHOICE study, it has gone up to 8%. So you get an 8% yield. That means you get to analyze much more abnormalities, as high as 8 to 10% beyond our microarray and karyotype. So we're coming to my last few slides. We've spoken about NT, which is seen during the first trimester scan, or an NT scan, say around 5 centimeter or 6 centimeter fetus. There are fetuses who come to us, or there are patients who come to us for early pregnancy scans, say around 10 weeks or so. Probably they come a little early. You get to see them a little early. Probably they ask for an appointment 1 week later, but the CRL is around 39 or 40 millimeter, or anywhere less than 45 millimeter. The cutoff for increased NT is 2.5 in them. And what do you do if you have an NT which is above 2.5 and the CRL is less than 45 millimeter? So people have gone through the data, and there are two schools of thoughts. That is, you do not terminate based on this NT of 2.5 when the CRL is only 45. So what do? You call them after 2 weeks, like how you do an NT scan and call them for an early target scan. If you analyze a nuchal edema, probably for a fetus which is CRL less than 45, you get them back at 12 to 13 weeks, and most of them could normalize. So what this study has indicated, there's probably a recent study around 2021 has got it published. Most of the time, that's the fetuses who have, where the NT is normalized during 12 to 13 weeks. So the same fetuses we have seen earlier with increased NT, these fetuses have 3 times lower chance of having an adverse outcome. Whereas when the NT has persistently been increased even at 12 to 13 weeks, then they have close to 40% of abnormal outcome in the when they are continuing the pregnancy. So it's very clear, when the CRL is less, you find a nuchal edema, and that nuchal edema is beyond 2.5 millimeter. Call them back after 10 to 15 days, reassess, and if that nuchal edema has resolved, then you know that these fetuses are going to be okay, or there is no proper, sorry for the spelling, there is no proper consensus whether to do an NIPT or invasive for such fetuses where the nuchal edema has resolved. But if the nuchal edema is persistently high, more than 3.5, you need to definitely offer them direct invasive testing, and depending upon the cost, depending upon the first or second or recurrent pregnancies, then you could offer them a microarray on a Rasoprati gene sequencing. So this is a checklist which was recently published in that article which I had shown in 2021. I thought it made a lot of sense, because the only point that these fetuses, or outside India, probably say in Australia or in UK or US, probably they offer them NIPT as their first line at around 10 to 11 weeks itself nowadays. Even before a structural, they do structurally screen the baby at 10 to 11 weeks, and they offer them an NIPT. So their protocol is what they have put, but it makes a lot of sense that if it is an increased NT, in spite of having a normal NIPT, then you need to make sure that you see the entire structural anatomy properly, either opt for a CVS at that point of time because the DNA is much, much better. Call them back for an early target scan at 16 weeks. If you have done a DNA sampling, say a chromosomal microarray is good, normal, then you call them back at 16, 18 weeks. If it is normal, then you have good load of 85% of favorable outcome in those fetuses. And if the NT is still high, then you can offer them a Rasopathy syndrome sequencing, a panel syndrome with amniocentesis. And in that panel, you can rule out Noonan syndrome. And if that is also normal and everything is good and 20-week scan is normal, then you can actually reassure them, because that's a very, very important point. 98% of them might have a normal outcome. So overall in a nutshell, where we have seen what is the criteria for increased NT? Yes, it's definitely above 3.5, and at 3 or 3.5, yes, that points in favor of 99 centile when the CRL is anywhere between 5 to 6 centimeters, number one. Number two, how would you counsel when it is isolated? Isolated increased NT is extremely challenging to talk to because when the rest of the fetus is structurally normal, we need to talk to the couple. The first and foremost concept of KT is gone now. It's about chromosomal microarray. We get an extra 6 to 10% yield in chromosomal microarray where we can identify much more copy number variants, number one. And if it's recurrent increased NT, the couple, we don't know what to do with them, then you definitely offer them a Rasopathy sequence to rule out Noonan syndrome. 50% of them the Noonan syndrome fall into the Rasopathy gene panel. And if you have done everything and everything has been fine and you're not able to ascertain the cause, then whole genome sequencing does play a major role. I think this paper recently, which was published last 1 year back, 2021 April, that's 2 years back, was an excellent paper. The clarity with which this paper was written was very, very impressive. And that's why if you are interested to know more, please do look into this paper. And thank you once again for this wonderful opportunity. I hope I was able to clarify what to do next when you find any increased NT.
Definitely, madam. Thank you, madam. It was a wonderful presentation. You just very nicely started by mentioning the importance of standardized technique in measuring the CRL and NT. And then you went on with, to clarify the doubt, what to take as a cutoff, whether it is 3 or 3.5 mm. Definitely, when it is more than 3 mm, we need to evaluate further for aneuploidy markers. The rest, look at the rest of the fetal anatomy, then go ahead with the karyotype depending upon or early target scan, and then if necessary, fetal echo depending upon the case. You also threw light upon the use of chromosomal microarray over karyotyping, Rasopathy testing, especially in isolated NT and when there is a normal karyotyping, and also about the role of whole exome testing in recurrent NT, which has a better yield. So it was very nicely brought out how to manage NT when it is more than 2.5 mm and when the CRL is less than 45 mm. So it was a great talk, madam. Thank you so much.
Thank you so much, ma'am. It was a pleasure.
Thank you, Deepti ma'am. Thank you, Shanti ma'am. Our next session will be on dialogue between Professor Bhuvna ma'am and Professor Rajlakshmi ma'am on clinical approach to early abnormal pregnancy. Dr. Bhuvna ma'am, she has been with me for almost 10 years now. She's an undergraduate from Stanley Medical College. She was the best outgoing student of 1990 batch with 8 gold medals. She's also a postgraduate from Gujarat University in 1999. She's a member of the Royal College of Obstetrics and Gynaecology since 2005. She was awarded the Fellow of Royal College of Obstetrics and Gynaecology. She's worked as a consultant in Sundram Medical Foundation for past 6 years from 2000 to 2006. She's currently the Associate Professor and Senior Consultant in the Department of Obstetrics and Gynaecology since 2006, with 20 years of clinical practice and 13 years of teaching experience. She has also been the guide to many postgraduate students since 2012 and published in national and international journals. So she has a special interest in laparoscopy and vaginal surgeries, participated actively in training students for the MRCOG, and has organized many postgraduate revision courses. I am also pleased to tell that she has been my guide during my postgraduate days. Thank you so much for all the learning experiences, ma'am. We're so happy to have you here today.
Thank you, Vangeline.
Along with Dr. Bhuvna ma'am, we have our Professor Dr. Rajlakshmi ma'am in this dialogue. Professor Rajlakshmi ma'am is Professor of Savita Medical College. She has many papers and publications in reputed journals. She's also an undergraduate examiner, guide and mentor of undergraduates and postgraduates. Thank you for joining us today, ma'am.
Thank you, Vangeline. Good afternoon, everyone. At the outset, I want to thank Hepzibah ma'am for giving this opportunity to participate in this Down syndrome symposium. I think we will start off. Early pregnancy is always a diagnostic dilemma. So Dr. Rajalakshmi is going to be there with me. We are just going to see. Dr. Raji, can you please tell why we do and what are the purposes of doing the first trimester scan?
Yeah, the purpose for doing first trimester scan is first we can confirm the pregnancy. We can see the we can see whether the pregnancy is viable or not. We can rule out ectopic pregnancy if there is any adnexal hemolysis, and we can rule out twin gestation, any abnormal pregnancies. And as early speakers have said about early fetal abnormalities, and we can also make out any uterine anomalies. And as nowadays the cesarean section is rare, so we can there are more chances of scar pregnancy, so we can make out scar pregnancy.
Yeah, that's nice that you elaborated. Now, more and more we heard about early genetic sonogram told by Dr. Sudarshan and Dr. Malti, and Deepthi elaborated on nuchal translucency. Apart from that, we also want to, as Dr. Rajalakshmi told, we are looking at the adnexal masses and cesarean section scar pregnancies being increasingly diagnosed. Now, let us make it more interesting. Okay, so Raji, you want to present the case?
Yes, ma'am. So we'll go to the first case. Mrs. S, 33 years. She comes on 20th of March 2023. She's married for 4 years with spontaneous conception and regular menstrual cycles. Her LMP is on 6th of January. She comes with 42 days of amenorrhea, 6 weeks, 3 days, with complaints of mild abdominal pain. There's no history of spotting, and her urine pregnancy test is positive. Her TVS scan shows a 10 × 10 mm regular intrauterine gestational sac, and there is no yolk sac seen. This is her TVS scan. So the couple is very anxious. So Bhuvana ma'am, how are you going to counsel this? When are you supposed to repeat the scan, and how are you going to counsel this patient?
Yeah, actually, this patient is a little old. She is 33 years, and when we look at it, it is 6 weeks, 3 days. Many of us know in a well-done transvaginal sonography, this patient has regular cycles, and she's already 6 weeks, 3 days, and she's 33-year-old with no comorbids. She's got only 10 by 10 millimeter gestational sac. Though it is alarming in my mind that it could be a possible failing pregnancy, because at 6 weeks, 3 days, you should be able to see a larger gestational sac, maybe a yolk sac and a fetal pole as well. But there are some limitations. Sometimes we may not see there might be a delayed ovulation, or there might be technical errors. So I wouldn't call it as a failing pregnancy at the moment, though it is not satisfying the appropriate gestational sac size. So I think we will repeat scan after 2 weeks. So the thoughts in your mind are that though regular cycles, so she's 6 weeks, 3 days, ideally we should see a good yolk sac, and delayed ovulation and technical errors. So I will not give false assurance that yes, everything will be fine. And at the same time, I won't put them down. So I'll just play neutral, because we are seeing a sac at the moment, and it is corresponding only to 4 weeks to 4 to 5 weeks. So we will repeat the scan after 2 weeks would be my counseling aspect.
So ma'am, how are you going to manage this case, and is there any role for progesterone?
There is NICE guidelines clearly say there is no role for progesterone at this point of time. However, as usual, we start folic acid, and we will instruct them to report if there is heavy bleeding. Only if there is a previous miscarriages, NICE guidelines say that we have to go on with the progesterone 400 micrograms vaginally, otherwise not necessary. So repeat scan, then after 2 weeks, it shows now mean sac diameter of 18 millimeter, and a yolk sac is also seen. There is a fetal pole of 2 millimeter, and there is no cardiac activity. Even at this point of time, though I am seeing a 2 millimeter pole, most of them 2 millimeter, 3 millimeter cardiac activity would have arisen by this stage. Only 5 to 10% of 2 mm fetal pole doesn't show a cardiac activity. But since the sac margins are regular, there is a growth delay. Definitely, we all know the CRL, the fetal pole grows 1 millimeter per day. We have given 2 weeks, 14 days, and still, because we have seen a fetal pole and yolk sac, we will repeat. Adnexa is normal. That's very important, and so So the doctor's mind voice is growth of the sac is still suboptimal. However, we may not see the heart in 10 to 20% of cases when the fetus is 2 to 3 millimeter. So I will not put down the diagnosis as a failed pregnancy at this point of time.
So her repeat scan after 1 week shows an MSD of 18 mm and yolk sac is seen and her fetal pole is 2 mm and there's no cardiac activity. What's
It
the
is the
diagnosis,
same,
ma'am?
isn't it, Rajiv? Same findings as we saw last week. Now we are more confident to say because the last week also 2 millimeter, now also 2 millimeter. It should have grown 1 millimeter per day. So we have given 1 week, it should have grown by 9 millimeter and cardiac activity should have been visible. Then we would have assigned an expected date of delivery a little later. But since now we are very sure when there is a fetal pole is only 2 millimeter and I would still present it as an early pregnancy failure. And when we don't see cardiac activity at 7 millimeter, but we have repeated the scan and there is no growth of these fetal pole. So if the fetal cardiac activity is not seen in a 7 mm fetus, it is called as a failing pregnancy or a missed miscarriage.
So the couple is very anxious and how are you going to deal with this anxious couple, ma'am? Can you tell us a few points for early pregnancy failure, ma'am?
Yeah, this patient, we cannot base the diagnosis only based on one scan because there is aging oocyte, she is 33, selection of gametes is by nature, we cannot select it. And we will, there can be a chromosomal problem. Most of the times that could be the reason for the failing pregnancy. However, we will also do a thyroid function test and diabetic check control. There is no role for APLA at this point of time. Lifestyle modification, weight reduction, if it is applicable, preconceptional, folic acid and psychological support is all they want because it is a devastating thing because they have conceived after 4 years. They are very excited. But the moment they are waiting, coming to you for almost 3-4 weeks to get a diagnosis of early pregnancy failure. So it is going to be a psychological upset as well. So reassured, most of the time, 85% of the time, they will have a normal pregnancy in the subsequent thing, provided they do all the investigations and follow folic acid and lifestyle modifications.
So what about the pointers for early pregnancy, ma'am?
So it will be, to call it as a non-viable pregnancy, neither a yolk sac nor the embryonic pole should be visible by the time when the mean sac diameter is 25 millimeters. We should avoid diagnosing abnormal early pregnancy just based on one scan. Repeat scan 2 to 3 weeks could very well establish the diagnosis. So the pointers for early pregnancy failure, as you asked Dr. Raji, I would say it is irregular gestational sac. There is a small disproportion between the sac size and the fetal size. And abnormally small, mean sac diameter more than 25 millimeter, but you don't see a yolk sac or a fetal pole, or absent yolk sac and a fetal pole, and no cardiac activity when there is a 7 millimeter fetal pole. An abnormally large yolk sac could be a pointer in a diabetic pregnancies. And if the CRL grows less than 1 millimeter per day, or there is a discrepancy in the CRL, and as I already told you, there can be disproportion between the sac, abnormally small gestational sac, disproportion between the CRL and the sac size. All these could be pointers for an early pregnancy failure, or there can be a large subchorionic bleed. All this may point, maybe this pregnancy is not going to further proceed. So the key points to be remembered while interpreting are the CRL is more reliable, means that diameter is more variable. Give more importance to crown rump length. However, we will not call it as crown rump length till the rhombencephalon is formed. So till around 14 millimeters or something, there can be a cephalic and caudal differentiation. Till then, we will take the maximum length. So midline sagittal measurement of the fetus in the horizontal position is taken. The endpoint should be taken clearly. An alteration of CRL by 2 millimeter can affect 10 percentile error in the growth, because we are going to assign the gestational age by only the calculating the crown rump length. If you make an error in the CRL, there can be a percentile error when we plot in the growth chart. So we have to be careful about it. And earlier gestational age, we cannot differentiate between CRL. Hence, greatest length should be measured. So these are all the important variables that we have to.
Is there any limitations for sonographic assessment of gestational age, madam?
Yeah, I don't know, something wrong in the thing. There are technical factors, obesity. There can be, instead of, some people will be using only a transabdominal sonogram. It is not very good. The person who is doing it, there can be obesity, fibroids, positioning, there can be biologic variation, there can be fetal anomalies. All this may alter. So there are some limitations. So we have to wait and repeat it, the scans, and be very patient before we give the diagnosis of pregnancy failure, because it is a patient, it affects the patient's lifestyle, and it is very important for them. Even if there is a 0.1% of chance that pregnancy could be viable, we have to give them a chance, is that my feeling. So this is an early pregnancy failure. After checking the hemoglobin, blood group, and viral markers, we would offer a medical abortion of mifepristone, and we will offer a medical abortion or a surgical abortion. Most of them will prefer a medical abortion and need for surgical evacuation if required. So now I want to discuss some case. This is Mrs. Kritika, who is 33-year-old, married for 3 years. This is a real case. She called me early morning on a Sunday at 5 a.m. that she has watery stools and she's got a pain in abdomen. What the hell, she is calling me at the morning 5 o'clock. Then I thought, okay, maybe she's got severe pain. I actually wanted to call up a physician or go and see a nearby doctor. Then something resisted me saying not to answer. I told her, come in the morning. By 8 o'clock in the morning, I'll see you in the hospital. Then I went on a Sunday morning just to see her, because she is a very sweet patient. So presented, she came with the history of vague abdominal pain, and she has loose stools for the past 1 day. She shifted to Chennai from New Delhi just 1 day back, and she had traveled the previous day. Her primary complaint was loose stools. She was trying to conceive for the past 1 year, and history of ovulation induction in the previous cycle. So this, do you think, Dr. Raji, triggers you some thoughts? What could be the reason?
Yeah, it can be due to ectopic pregnancy, ma'am, or early pregnancy failure. So I would like to know about her LMP, ma'am.
Yeah, her LMP was menstrual history. She did not miss a cycle. She had LMP was 15 days back, and she lasted for 2 to 3 days. Now again, she has got spotting. What would you like to do?
Is there any history of I will ask her whether there is any history of missed cycle, irregular bleeding, a scanty cycle.
She did not miss the cycle. Her LMP was 15 days back, which lasted for 3 days. After which again she started bleeding, and she has a pelvic pain and the diarrhea. So
I'll go for. I would like to go for a TVS scan, ma'am.
Yes. Before that, I think we have to probably do a urine pregnancy test as well. Yeah. So there is what are the factors which will make you suspect from the history this patient could be having a possible ectopic pregnancy?
So her missed cycles, irregular bleeding. She's having history of diarrhea and loose stools.
Yeah. So history of infertility, history of tubal surgeries, history of assisted reproductive techniques, previous history of pelvic inflammatory disease. So these could make you suspect that can be an ectopic. Can you elaborate what are the sonographic markers in an ectopic pregnancy?
Yeah, yes, ma'am. If there is any absent intrauterine gestational sac, there is presence of ring of fire appearance in ultrasound. If there is any free fluid or presence of any adnexal masses, and presence of adnexal mass with cardiac activity, and pseudo gestational sac if it is centrally located in the cavity, because in normal pregnancy the gestational sac will be eccentrically located.
Exactly. The normal intrauterine gestational sac is eccentric in location, and it has got a double decidual sac sign, whereas a pseudo sac is just a fluid filled structure. It occupies the central portion of the cavity. So that is why sometimes we get differentiated. So this patient had a pallor and vitals were stable, precord was positive, and ultrasound showed an absent gestational sac, thick ET, and adnexal heterogeneous mass. So there was no cardiac activity, but free fluid was present. So at this point of time, which would be the appropriate line of management for this particular patient, Dr. Raja?
So in this patient, as she's giving history of vague abdominal pain with loose stools, and her ultrasound is showing adnexal mass with free fluid, the chances of tubal abortion should be considered. So I would like to go for laparoscopic management about laparotomy.
Exactly. So because of the presence of free fluid and the large heterogeneous mass, we thought of doing a laparoscopy. We didn't go for a medical management because already she had a pelvic diarrhea and she had a leaking tubes, which is tubal abortion. Adnexal was more than 5 centimeters, and there was presence of free fluid. And this is the picture of this particular patient. When early morning, when she called me at 3 o'clock, I never thought this could be my patient, but I was actually very humbled to see God has given me, did not make me here with the patient, and I could treat her at a timely manner. And this is what I saw when I put in the laparoscope. There was a lot of free fluid and there was a huge mass. Luckily, laparoscopic salpingectomy was done and she was discharged the next day. And by God's grace, she conceived within 6 months and delivered a 4 kg boy by LSCS, and child is now 2 years old. So this is just for the discussion. So counseling tips, what are the, in case if you are giving a medical management, what are the things you will tell Dr. Raji, if you are starting a patient on a medical management?
So regarding the counseling tip, we should counsel the patient about the failure of medical management and need for surgical intervention anytime if it fails, if there is any rupture. And also about the methotrexate toxicity, we are supposed to counsel.
Yeah, that's very important. We have to give folinic acid rescue following every dose of methotrexate, because 1 in 1 lakh can develop a fetal liver toxicity. They can develop jaundice, elevated liver enzymes, or they can go for a bone marrow suppression. So before giving every dose of, if you are going a multiple dose also, we have to do a complete blood count and a liver function test before giving every dose of methotrexate, and it should be followed by folinic acid before you give a repeat dose of methotrexate. So she is yeah.
So we'll move on.
Yeah, okay. We'll move on to case 3. Yeah, you want to present? Yeah, present, Dr. Raj.
Mrs. K, 23 years old, married for 6 months, a primary gravida, LMP 45 days back, and her urine pregnancy test is positive. She comes for regular checkup. Her TVS pelvis shows no evidence of intrauterine or extrauterine pregnancy.
So now at this point of time, when the transvaginal sonography is showing no evidence of pregnancy, but the urine pregnancy test is positive, we usually asked for a beta HCG and it came as 750. Do you think at the values of 750, you can see a gestational sac inside the uterus?
No, ma'am.
So even with the current high resolution transvaginal sonography, probably by 1000 or 850 to 1000 international units, we may pick up a very small sac. But at this point of time, the beta HCG values is very low. So we thought we may not take it may not show a intrauterine sac. Yeah.
So her repeat beta HCG after 48 hours is 1030, and she's complaining of pelvic pain, and the scan is repeated.
So it should have doubled by 48 hours. By 750, we should have had a value like 1500, but it's only 1030. So it's very tricky. So we don't know whether it is a failing pregnancy or whether it is an ectopic, which is slowly increasing the beta HCG values. So what do you think? She complains of mild pelvic pain. There are certain cases in which you just give an expectant management. You don't do a medical management. You don't do a surgical management. Just closely monitor the patient. So the scan was repeated and there was no evidence of intrauterine sac, but the adnexal mass of 2 centimeters was found in the adnexa. There was no free fluid. So do you think, Dr. Raji, this patient is a candidate for an expectant management or a candidate for medical management with methotrexate?
We can go for expectant management, ma'am. Since her beta HCG is less than 1500 and there's no evidence of rupture in ultrasound, and and there's no obvious adnexal masses, and if she's asymptomatic, we can wait and watch, ma'am.
Yeah, this is very tricky because between the values of 200 to 1500, we can give expectant management. Just watch the patient closely for any hypotension, pallor, etc. But however, because there is a adnexal mass of 2 centimeters, you have to closely follow the patient, and the subsequent values of beta HCG should reduce. Then you can give expectant management. If you feel that the beta HCG values are increasing, then you stop the expectant management and go off to the medical management. Can you also tell what are the criteria for managing, giving a medical management for ectopic?
Yes, ma'am. The adnexal mass should be less than 3.5 centimeter in size. There should not be any cardiac activity. The beta HCG value should be less than 5000. And the patient should be hemodynamically stable.
Yeah, we all have seen when there is a cardiac activity or when the beta HCG is close to 10,000, most of them fails. But my postgraduate Suganya did the thesis on the medical management with methotrexate. We had 85% success rate. Only 15% of them had to undergo surgery. Out of 50 patients, more than 40 patients were successfully cured. Even we had one case, we had included 8,000, 10,000 also. So that we don't know what are the predictors, but presence of cardiac activity or presence of free fluid or a large adnexal masses are contraindications for medical management with methotrexate. So we just move on to case 4. She is Mrs. R, unmarried. She is unmarried. Recently, I got this patient just 2-3 months back. She is unmarried pregnancy. She had taken medical abortion for early pregnancy 3 weeks back from Hyderabad. She presented to my clinic with history of mild abdominal pain on and off and bleeding for the past 1 week. Her urine pregnancy test was positive and she was worried if the pregnancy is ongoing. How to proceed, Dr. Raj?
So I would like to ask a few more histories to her, ma'am, like
Yes.
any history of passage of tissues or clots to confirm expulsion of PC products of conception, whether she had any history of missed periods, whether she had ultrasound done, and whether the medications were given by a consultant or it was taken over the counter.
Yeah, these are all very important because most of the practitioners outside, they don't check whether it was intrauterine or extrauterine. They just give some of the women, because they are scared, they go to the medical shop and get the tablets on their own without checking whether it was ectopic or intrauterine. We have had patients coming to the emergency room with ruptured ectopics when they have taken medical abortion without a consult by the OGCM. And any scans are done. No scan was done for her before administering the medical abortion tablet. So we don't know whether it was an intrauterine gestational sac or it was ectopic, because her urine pregnancy test still tested positive even after 3 weeks of medical abortion. Usually we expect the beta HCG to go down linearly, and 3 weeks now from the medical abortion, she had history of passage of clots, but she did not pass any tissue. So the gestational age was around 6 weeks when she took. So she did not have any giddiness, or she only had a mild pain. On beta HCG, when she came to me, I ordered on 7th January, it was 1,750. And on 9th January, it was 2,000. So what are your thoughts about this? There is an ongoing trophoblastic activity, isn't it? And it is showing a increase. So that is what is... A repeat scan showed no free fluid, no evidence of retained products, because we will think in terms of retained products because she took medical abortion. But however, it looked like a complete abortion. Endometrium was so thin and there was no free fluid. Neither there was a gestational sac in the adnexa, and neither there was no abnormal vascularity in the endometrium or the myometrium. So my only thought was whether the early pregnancy would have been a vesicular mole, whether it got expelled on its own, or I don't know, because there was no scans done prior to this, we don't know. And anyway, for purpose, we repeated the beta HCG. There can be an ongoing ectopic pregnancy, but it is quite unlikely this is on for the nearly 4 weeks, 3 weeks before she took medical abortion. Now the values are increasing. There can be a possible persistent trophoblastic disease following a VMOL. We don't know, but now at the moment, we just closely monitored, repeated the beta HCG after 48 hours, and it showed an increase on 11th January. It increased from 1,750 to 2,000 to 2,500. Now it is a clear alert. There is an ongoing trophoblastic activity. So whatsoever reason, we offered her either an expectant management or a medical management for methotrexate. Patient opted for methotrexate, followed by folinic acid rescue, and thereafter the beta HCG started coming down. So when do you suspect a persistent trophoblastic disease?
If there is any raising beta HCG or plateauing beta HCG values, we can suspect
particularly following an evacuation of VMOL. But in this particular patient, it was just following a medical abortion 3 weeks later. So this was a very tricky case. I really didn't know how to proceed, but because we just handled the trophoblast, and anyway, I'll keep the patient under follow-up and see what happens. And you also have to probably look at the vascularity in the endomyometrial junction, look for invasive mole, all that. We want to present the case 5.
Yes, ma'am. Mrs. P, 24 years, Gravida 2, Para 1. Gravida 2, Para 1, Live 1. First is a full-term normal delivery, boy baby, alive and healthy. Second is the present pregnancy. She's married for 4 years and she presents with history of bleeding PV on and off at 11 weeks of gestation. So how are you going to?
Yeah, this patient, at 11 weeks, because she presents with bleeding, we will ideally earlier in the scans were normal and she was started on progesterones. We reassured the patient. And maybe there is this ultrasound showed low-lying placenta and the fetus was active. So we probably thought the bleeding was due to low-lying placenta, and I just reassured the patient and started on progesterones. There was no evidence of subchorionic bleed, and the couple was anxious because they had quite a lot of blood, and reassured and explained that it might be due to low-lying placenta.
So 1 week later, she again presented with another episode of bleeding, and this time she had one full pad soaked, and she's complaining of fleshy thing through vagina visible, and speculum examination shows 5 × 6 centimeter endocervical polyp. How are you going to manage?
Yeah, this patient was delivered by me in the first delivery also, and I had followed up with a pap smear. And because all that was done by me, I never, even I skipped the protocols. I didn't do a speculum examination. But patient told me that there is some fleshy thing coming through the vagina. That time I put a speculum, I saw a big endocervical polyp. So I just, because she was only 12 weeks, I just clamped the endocervical polyp and just ligated it and cut it out. And after that, the bleeding totally stopped and stopped the progesterones, and patient was very happy that the bleeding stopped. And don't think that all the low-lying placentas only will bleed, or there can be a subchorionic hemorrhage. So if we skip steps, there can be some surprises, and patient herself told some fleshy thing coming out through the vagina. So I felt a little why I didn't do a speculum examination, because I was following the patient from the beginning. I thought her cervix was normal. So moral of the story is all low-lying placentas don't bleed. You may have a surprise, follow protocols, always do a clinical examination. So endocervical polypectomy done, and she was doing fine. So that's a moral of the story. So a little word about a subchorionic hemorrhage, Dr. Raji.
So this, most of them may continue. You can reassure the patient, and can some of the patients can go in for first or second trimester miscarriages.
When do you think it is more very dangerous? When do you think the subchorionic hemorrhage can be more dangerous? When there is more than 25% of the volume of the gestational sac is lifted. That is the time the meta-analysis have shown that the pregnant individual with subchorionic hematoma had double the odds of the pregnancy loss compared with those without subchorionic hemorrhage. So that when there is a subchorionic, significant subchorionic bleed can be associated with first and second trimester losses. So we have most of the other times, usually we have to reassure and make them continue. So the take-home messages are: early abnormal pregnancy poses a lot of mental stress to the couple. Establishing the diagnosis of early pregnancy failure by doing a couple of scans is not bad to reassure and make sure definitely it is an early pregnancy failure. Interpretation of the scan and beta HCG and clinical examination of the patient is a cornerstone for deciding the mode of management in the ectopic gestations. And a high degree of suspicion. Ectopic pregnancy is seeing an owl in the dark night. I used to tell my students, you cannot see a dark, in the dark night, you cannot see an owl by just looking at the eyes. So only your mind thinks it could be ectopic. Whenever a patient in reproductive age group complains of pain abdomen, always do a beta HCG is what is the take-home message. Early pregnancy bleeds are always not due to subchorionic hemorrhage or low-lying placentas or missed miscarriages. Rule out cervical and vaginal causes as well. Thank you so much. I hope it was informative to all.
Thank you, ma'am.
Very nice dialogue, Dr. Bhavana and Dr. Rajalakshmi. Like you said, many of the women, they take over-the-counter prescriptions for MTP.
Dr. Rajalakshmi, switch on the video.
There is no protocol that says that patient should have an ultrasound before going in for an MTP with the medical method. And that's a problem. I think we should have a high index of suspicion. In our institutions, we do it.
Yeah, we true, ma'am. But many times those who are taken medical abortion land up with complications like ectopic and some persistent disease like this. It is a dilemma for us now how to manage. If she had had a scan, it would be easy for us to label the diagnosis.
I agree with you. That is what I'm saying. Maybe the FOGSI should take it up, because they're offering MTP left, right, and center with medical abortion. They say it's the right of the woman. But then who's responsible if she has an ectopic and it's missed out? And the prescribing physician is also in a suit. Maybe it should be made mandatory to have at least an intrauterine pregnancy confirmation before going in for that. That's what it is.
Thank you, ma'am. Thank you, Epsiba ma'am, for this opportunity. Thank you, Dr. Rajalakshmi, for joining me with the dialogue. Yeah.
Thank you, ma'am.
Very nice. You have touched up on all the aspect, and it was interesting to listen also. Thank you for sparing your time.
Thank you. Thank you.
Ma, this slide, stop sharing, no? யார் ஷேர் பண்றா?
I am only sharing, ma'am. How to stop sharing? I don't know. One second. They started. How do I?
The view option, let's stop.
Stop share. Yes, I got it. Sorry, ma'am. Yeah.
Yes, yes. No, I just want to take one photo. Okay. Thank you. Thank you. Thank you for the nice interactive.
Thank you, ma'am.
Thank you.
Everyone, I now request my assistant professor, Dr. Archana ma'am, to give the vote of thanks.
Hello everyone. Dr. Evangeline, am I audible?
Yeah, you're audible, not visible.
Okay, I don't
Thank
know
you,
how-
Hepzibah ma'am, for the opportunity. It was a nice
Good evening, everyone. It has been such an honor to be a part of this wonderful webinar. On behalf of Fetal Medicine Unit of Department of Obs and Gynae, Savita Medical College and Hospital, I take this opportunity to propose vote of thanks to those who have been directly or indirectly contributed to this webinar on Down Syndrome Awareness Day. I express my deep gratitude to our Chief Patron, Founder Chancellor, Dr. N.M. Virayan sir, and I thank our Chief Guest of Honor, Dr. Deepak Nallaswamy sir, and Director Savita Medical College and Hospital, and Dr. Professor Deepika Dekha ma'am for gracing this webinar. My heartfelt gratitude and respect to our distinguished chairpersons, Dr. K. Jayashree madam, who is our head of department, Dr. G. Rohini madam, Dr. E. Shanti madam, and Dr. M. Rajalakshmi madam, and our eminent speakers for not only eminent speakers are Dr. S. Sudarshan sir, Dr. Malati Prasad ma'am, Dr. Deepti Jami ma'am, and Dr. Bhuvana ma'am, for not only sparing their valuable times for us to grace this occasion, but also for enlightening us with their commendable talk on the subject. Thanks all of you for clearing our concepts and enhancing our understanding pertaining to first trimester sonographic assessment of the fetus. I would like to thank our speaker, Dr. Sudarshan sir, for talking about sonographic assessment of fetus at 11 to 14 weeks and advising us to change the NT scan referral form as a first trimester evaluation form. And I'm sure that many of us, we are going to follow in our day-to-day routine life. A special thanks to organizing team, Dr. J. Damodaran sir, Dean Savita Medical College and Hospital, Dr. N. Hepzibah Kirubamani ma'am, who guided us through the Fetal Medicine Fellowship Program and mentor various webinars and seminars. I would like to extend my special thanks to my head of department, Dr. K. Jayashree madam, for supporting us in each and every aspect of academic activity. My heartfelt thanks to all active participants also. Last but not the least, I would like to thank Mr. Balaji Venu Company, who has provided us the technical support so that we can run our webinar smoothly. And with this warm words and kind message, we move to the end of the today's webinar. Thank you. Thank you, everyone.
Thank you, ma'am.
Thank you. Thank you, madam.
Thank you, ma'am.
Thank you, ma'am.
Thanks, Evangeline. Thank you, Rohini ma'am, Hepzibah ma'am, Jayashree ma'am.
Thank you, ma'am.
See you.